न्यूरोज्ञान यूट्यूब चैनल पर आपका स्वागत है। लेटेस्ट वीडियोस के लिए अभी सब्सक्राइब करें।
Neurosurgery for neurosurgeons. A few maxims, some telephone messages, pulse and pitfalls, and outline of the syllabus. I have taken a slightly different approach than what Professor Chandrasekhar did. Ujjain. He talked about the recent advances in neurosurgery, which we neurologists should be aware of. I am not talking of recent advances in neurology, but my presentation is more geared towards the residents or the students. Now this subject brings a nostalgia to me of my good old days. At AIMS during 1983 to 86 when I was doing my DM, we used to have joint rounds with neurology department, and I am proud to say that I have learned a lot of neurology from neurosurgeons, Professor P.N. Tandon and other faculties at that time. I also remember fondly the annual meetings of Neurological Society of India prior to 1990, and again I will say we have learnt a lot from each other. Those things are missing now, except in the state level meetings like this, the Society of Neuroscience for MP and CG, they are the saving grace. There are textbooks on neuroscience for neurosurgeons, and in a textbook by Oxford Race titled The Neurosurgeons Handbook, there is a chapter on neurology for neurosurgeons, but I have used my own approach. There is a symbiosis between the physicians and surgeons because our ultimate goals are same. The anatomical, physiological and pathological substrates are partly same or mostly same, and the methods of clinical assessment including history taking, physical examination and interpretation of investigations are also mostly same. However, there are asymmetries and differences. The temperamental, philosophical and personality differences between surgeons and physicians have long been talked. There is more emphasis and importance of history taking and its interpretation for a neurophysician. Neurologists cannot do surgery, but they can medically treat many neurosurgical ailments. Neurosurgeons can treat some neurological conditions, but they need training. And hardcore neurological conditions to which neurosurgeons are not exposed, they are too many, they are too numerous in the community, and they are too complex for them. However, there are many medical conditions which are amenable to surgery like epilepsy, movement disorders with stereotactic and functional, psychosurgery for addictions and OCDs, chronic intractable pains, spasticity and some neuropathies. So the neurosurgeons who are specializing in the surgical treatment of these conditions, they need to be well versed with the medical management of these conditions also. The history taking by a neurologist is more time consuming, and while eliciting history, the first rule is let the patient and caregiver speak and do not interrupt at least for the initial 2 minutes, and no irritation. Make rough notes either in your mind or on paper so as to keep ready the leading questions in your mind and ask them only when patient has completed. While listening to the story, think anatomy first. So if a patient has come with acute onset weakness on the right side of the body with loss of speech, the first idea should come to your mind. This is the left frontal temporal lobe or left MCA territory. Think anatomy first as soon as you are listening to the story. Then think pathology second. Because it has come acutely, it is likely to be a cerebrovascular accident. And then because the sufferer is a young female of 30 years with a rheumatic heart disease and atrial fibrillation, think etiology third. It could be cardioembolic stroke. And because the patient is having a degree of hemiparesis in terms of an IH stroke scale and modified Rankine scale, think deficit and handicap fourth. So this should be the sequence of thinking while you are eliciting the history. And of course, family history may be more often positive in many neurological disorders. The physical examination by neurologist also differs to some extent by the physical examination by surgeon. In a neurology case, there is more importance of general systemic examination. Because we are MD medicine physicians, also we are able to examine cardiovascular, GIT and respiratory system in more detail. We should never forget optic fundus. It requires devoting more time to higher mental functions like orientation, memory, executive functions, and the neurosurgeons will have to train themselves, and I will advise them, please download on your smartphone the mini mental status examination, the Montreal Cognitive Scale, the NIH Stroke Scale, and a few more. So it has become so easy nowadays, you can do the bedside assessment of many of these higher mental functions. We physicians, when we examine a movement disorder, we go into a slightly more detail. We describe the phenomenology, the anatomy, the rhythmicity, the rate, amplitude, effect of rest, effect of posture, effect of kinesis. So description of a movement disorder under examination should be covered under these headings. And then when we examine polyneuropathy, we look for protopathic and epicritic sensation and dissociate sensory loss. We describe the anatomy. And when we examine the myopathy, we do the manual muscle charting of individual muscles. It is not enough to say proximal versus distal, and you have to, because myopathies have very peculiar patterns. Supraspinatus may be involved but not the intrascapular. Deltoid may be involved but not the biceps. So facioscapulohumeral muscular dystrophy will have a different pattern. Limb girdle muscular dystrophy of type 1A will have another selection of muscle pattern. And similarly for neuromuscular junctions, we look for the phenomena of fatigability by repetitive testing. So for example, ask the patient to do arm abduction 20 times and examine the power in deltoid before and after the arm abduction 20 times. That's how we document fatigability. Of course, every neurosurgeon must learn by heart the warning signs of stroke, the be fast, and not only learn them by heart, he should popularize them and institutionalize them. It is the duty of every neurosurgeon, not only neurologist, to popularize the warning signs of stroke. And what do I mean by institutionalize them? If you are a neurosurgeon in an institution, you should look that your hospital, right from the reception, right from the telephone, right from the ambulance, right from the ICU and imaging, they should be geared that a stroke patient should be a first priority for the management. That institutionalization is a responsibility of a neurosurgeon also in a hospital. The first aid of a stroke should be known to every neurosurgeon, particularly while you are waiting for a transfer. Let the patient be supine and resting. Get an ECG, some baseline investigations. Don't touch the blood pressure. Let it be whatever it is. And get a CT scan first. Do not waste time on MRI in the beginning. Of course, MRI is important. And if there is no hemorrhage on CT scan, even in a peripheral center, load the patient with aspirin 300 milligram and arrange urgent transfer to a stroke ready hospital. What do I mean by stroke ready hospital? The one with CT scan, MRI, preferably a cath lab, a good ICU, a good laboratory, a neurosurgeon and neurophysician being available, and chase the time window. And also do not neglect TIA. If the patient is improved by the time she came to you, that doesn't mean you give an appointment and ask him to come the next day. Every TIA should be investigated like an emergency stroke, even if the patient has recovered. For IV thrombolysis, 3 to 4.5 hours, but sooner the better. And if the time has passed beyond 4.5 hours or a wake-up stroke, even then, up to 24 hours, there is a role of MRI. Look for mismatch on MRI or ask your radiology colleague to report on mismatch between DWI and flare. And if that is there, you talk to an interventional radiologist or a neurologist for the feasibility of a mechanical thrombectomy in a large vessel stroke. So if a neurosurgeon is not taking care of this mismatch and not asking for an interventionist, he is not doing his duty. So don't say, oh, it is already 4.5 hours, what could have I done? Your duty is still beyond that, and your duty is still beyond that. Of course, you must be beware of stroke mimics. I will not go into the details. seizures with post-ictal deficit, migraine with neurological aura, fainting or syncope, infections, toxic and metabolic abnormality. For example, hypoglycemia. A patient with a hypoglycemia of 30 or 40 blood sugar can present with hemiparesis. Why? Because there was a global reduction in the cerebral metabolism, but all parts of the brain didn't hypofunction equally. Those parts which were already having a stenosed artery on one side, that part will become more damaged in hypoglycemia, and patient can have focal deficit in hypoglycemia or other metabolic encephalopathies. Functional neurological disorders, hysterical patients. There are many neurological signs which help to differentiate an organic neurological deficit from a functional deficit. Brain tumors and subdural hematomas can occasionally present with acute onset and reversible neurological deficits. So these are all stroke mimics. Regarding stroke care beyond 24 hours, ensure that the patient goes to a stroke unit where the homeostasis, the milieu interior is maintained with the help of supportive and symptomatic treatment, with the help of judicious anti-edema measures and surgical decompression in selected cases. And every neurosurgeon should advise the family about secondary prevention. Even if the patient has come to you, say, after 1 month, you should investigate and look for the risk factors like hypertension, diabetes, tobacco, alcohol, lipid, exercise, and never forget rehabilitation. Refer, persuade, and follow to go to the occupation therapist, physiotherapist, speech language therapist, and clinical psychologist. So that was about stroke. Core messages about epilepsy are: the first state of an epileptic seizure should be known to every neurosurgeon. Management of status epilepticus should be known to every neurosurgeon. Please read them, please download them. Follow a semiology based description and classification of seizures. The classification, international classifications keep changing every few decades. Try to stick to monotherapy while ensuring gradual titration and monitoring of side effects and drug levels and compliance. Avoid polytherapy as much as possible. You should do the up titration in a gradual manner. For generalized epilepsies, remember valproate is the drug of choice. First state of seizure should be well known to you. Flowchart for management of status epilepticus should be learned by heart by every neurosurgeon. I am not going into the detail. A minute about headaches. Learn by heart the diagnostic criteria of common headaches as offered by the recent edition of International Headache Association. All these things are easily available. So those things you have to learn. Regarding migraine, the core criteria are: the headache characteristics should have at least 2 of the 4. What are the 4? Unilateral location, pulsating quality, moderate or severe, and aggravation by physical activity. Out of these 4, if 2 criteria are there, it is okay. The second part is, during the episode, there should be nausea, vomiting, and photophobia and phonophobia. If these criteria are fulfilled, there is no need for CT scan, MRI. The diagnosis of migraine and tension type headache is purely clinical. In fact, it is purely history based. There is no need to touch the patient to make a diagnosis of migraine. Of course, you will examine the patient thoroughly. That goes without saying. Similarly, these are the diagnostic criteria of tension type headaches. Again, I will skip over. So, core messages about the treatment of migraine, because migraine is such a common condition. Neurosurgery practice will have migraine patients. Regarding the acute symptomatic treatment, you can use paracetamol with metoclopramide combination, or NSAID or opioids or triptan. But beware of the overuse of analgesics. A patient should not be taking analgesic more than 3 to 5 days in a month, not only for side effect, not only for dependence, but also for a phenomena called rebound headache or analgesic overuse headache. So you should counsel the patient. Long-term prophylactic treatment is indicated if the headache frequency and particularly the severe headaches are occurring more than 4 to 5 times per month. You have to gradually up titrate the dose of propranolol or amitriptyline or topiramate or some combination, and you have to gradually increase the dose. There are some red flags regarding the headache, type and location and triggers and duration and other symptoms and age, which indicate that it could be a severe sensory headache or secondary headache. Then there are some pathological processes which are not commonly encountered by neurosurgeons. They include toxic, metabolic and nutritional like vitamin deficiencies, hepatic and renal encephalopathy, electrolytes, hypoxia, drug overdose. And what are the common characteristics? They are always symmetrical. They have particular syndromic constellation. They are not localizable in anatomical terms, and they often have other systemic features. Another group which is not commonly encountered by neurosurgeon is demyelinating and autoimmune. The examples are ADAM, MS, neuromyelitis optica, autoimmune encephalitis, paraneoplastic. And what are the common characteristics? They are often symmetrical, but they can be asymmetrical also. They can be monophasic like ADAM, or they could be multiphasic with relapses and remissions like multiple sclerosis. And another pathological process is degenerative. And the examples are motor neuron disease, Parkinsonism, Alzheimer's, spinocerebellar ataxia, myopathies, neuropathies. And what are the common characteristics of degenerative conditions? They pick and choose specific cell and tract. Motor neuron disease will only choose pyramidal Betz cells in the motor cortex and Entrehan cells in the spinal cord. The dopaminergic neurons will be selectively damaged in substantia nigra in Parkinsonism. The cholinergic neurons in the hippocampus will be selectively damaged in Alzheimer's dementia. The Purkinje cells will be selectively damaged in spinocerebellar ataxias. So these conditions are usually symmetrical. They always have gradual onset, they are slowly worsening, they are mostly untreatable, and they are not localizable to a single anatomy, and they may often be familial. So this is my concluding quotation from Sir William Osler, who said, he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to the sea at all. समुद्र तो आपको जाना ही पड़ेगा. Thank you very much.